We'll be talking about telehealth and the law, and I'm Dr. Jorge Wong. I'll be your moderator for the panel. I also wanted to share and remind folks that the video by Dr. Michi Fu is in the expo session. So if you're interested in looking for that, please go to the expo session. Given the amount of time, I'd like to welcome our panelists, and I'll do a quick introduction, and then we'll just jump into questions, and we'll go from there. So first we have Joseph McMenamin. Please correct me if I'm mispronouncing your name.
Well done.
Thank you. He is the founder of the McMenamin Law Offices in Richmond, Virginia, a healthcare boutique emphasizing in the law of digital medicine and artificial intelligence in healthcare. He's also a graduate of the law and medical school, so double degree, of the University of Pennsylvania, and served an internal medicine residency at Emory. He's a board certified in legal medicine, an associate professor of legal medicine at Virginia Commonwealth University, and a fellow of the College of Legal Medicines. I guess he's quite busy, but let's check the other panelists. John Mills, he's a partner at Nelson and Hardiman, a nationally renowned healthcare specialty law firm, and he's the co-chair for its litigation team. John has been recognized as by the best lawyers in America for his work, in particular in healthcare law for 5 consecutive years, 2016 to 2020, and in administrative regulatory law for the last 3 years, 2018 and to 2020. John has also been named in either Southern California Rising Stars or Super Lawyers list 8 times. So, folks, we have a star-studded panel of attorneys and MDs here. So, with that, let me start with the first question, and then we'll go to Joe. So, Joe, what kind of preparations should a clinician perform prior to providing teletherapy to ensure compliance with legal and ethical statutes?
Well, thank you, Jorge, and thanks to TogetherWell for organizing the meeting, to all of you for coming. That's a tall order to ensure compliance, but there are several steps that I think are worth considering that will certainly improve the probability that your care will indeed comply. And I divide them into categories. One I think of as professional to mental health, one is insurance, one is tech preparation, what I call website manner that I won't spend a lot of time on, the provider relationship, consent, and licensure. With respect to the professional aspect of this, the first step I would suggest is to determine whether telehealth is an appropriate modality for evaluating and treating your particular set of patients or a given patient. And if in your judgment, the nature of the problem suggests that in-person evaluation is really important, then I would decline the case and demand to see that patient in person rather than trying to do it in a fashion that's not well suited to that individual's needs. In general, I recommend avoiding the care of emergencies, if at all possible, using telemedicine. Sometimes it's unavoidable. And so in the event that that should happen in the middle of a session, I think it's a good idea in advance, if at all possible, to try to develop contingency plans should emergencies arise, such as developing an understanding of the 911 capabilities in the areas where your patients live, to identify a friend or a loved one and get contact information for that individual in case the need should arise, and to create a backup method to contact the patient if for some reason you should lose the connection in the middle of the session. Let me turn to insurance. The second case there, I think you should contact your broker or your agent about your professional liability insurance and general liability coverage for telehealth services. Unfortunately, given us a pass on ransomware remains a serious problem, often a very expensive one. So it would be a good idea most of the time to purchase cyber insurance. Generally, it's not outrageously expensive, and it can provide a little peace of mind and some protection in case the need should arise. A third category of preparations is technological. I think it's a good idea to determine what sort of training you and your staff may need to operate the software or the platform that you're using. You may very well be able to rely upon remote learning modules to do that. If you can provide resources to your folks, questions on technical issues and so forth, that's valuable. Try to stay updated, of course, on the latest research and publications, and stay informed as well on regulatory requirements, particularly in this COVID-19 era where the law seems to be changing at a rate I've never seen before in my years of practice. It's a good source of information is often your state health department's COVID resource page. Just about every state now has something like that. Then on website matter, the next category, I won't spend a lot of time because I think in the previous session, some folks already talked about that. My general overall advice is to act pretty much as you would if it were an in-person setting. Astonishingly to me, I actually had to speak with a physician who was contracted to a telemedicine company of mine about the fact that he was smoking during his visits with his patients. That sort of thing is obviously problematic and should be discouraged. The provider-patient relationship is very important. It's generally a matter of state law. There's been some relaxation, as many of you may know, about reimbursement rules regarding phone-only care. And that's great for Medicare reimbursement purposes, but if your state demands that some other form of communication, such as audio-video, is required to have a proper provider-patient relationship, then what Medicare says about reimbursement has nothing to do with your requirements under state law. Consent, I think pretty obviously you need to obtain and document it. One of the things I would suggest on that under that heading is that if you are using Zoom or Skype or any of the other technologies now permitted, that you explain among the other risks and benefits that you talk about, that the privacy and security of the information to be exchanged between you and the patient may not be quite as stable, not as certain as it would be under ordinary circumstances when that sort of technology is generally not accepted. And finally, licensure, you need to determine whether, as an out-of-stater, if you are in fact offering services out of state, you can practice without a license in the patient's state. That's a question of state law. Until very recently, the answer was no, you couldn't. You always had to have a license in that state. But under COVID, a lot of states have relaxed their laws, and you should determine not only what their current state of law is, but also the duration of any waiver of licensing requirements that may currently exist. I think it's a good idea to determine whether the patient's state requires any form of special registration and to document the patient's location at the start of the visit, just in case licensure questions do arise.
Wow, that's lots of useful tips and things to keep in mind. So in regards to the legal part, let me check in with John and ask, what are some of the more common questions you get asked, and in particular with ethicals and legal statutes that providers should be aware of or be concerned about?
Sure. Well, I think Joe just touched on, I think, pretty much all of them, if not definitely the main ones, if not all of them. In terms of legal, of statutes that we are constantly looking at when we're advising clients on teletherapy and any telehealth, frankly, licensure is always a big one. If the patient and the provider are in the same state, it's not going to be an issue. But with teletherapy, we often are finding we're getting questions. Well, can I give a teletherapy session to a patient, a client who's located in another state? And as Joe touched on, that comes down to state law. Is you have to, if I'm in California, and that's, by the way, that's where I'm located, everyone, and so I might be a little more California centric in terms of how I answer some of these questions. But if I'm in California and my patient is in Arkansas, for example, the first thing I need to do is check with Arkansas and see, do I need a license to provide therapy in that state? Definitely right now, under the circumstances with the COVID-19, there is definitely a lot of relaxation. Even before the relaxation, there was, there are some organizations that do, national organizations that do certifications, and a lot of states were already relaxing their standards and allowing for certain certifications. California is not one of those, by the way, but other states are. But right now, with the COVID crisis, there is more relaxation in terms of expediting processing for a temporary, I wouldn't call them licenses, but temporary certifications, temporary the ability to see patients across state lines, because a lot of people have been displaced as a result of the crisis. Another big issue, of course, is consent. We always make sure that that whatever state the patient is in, does that state require specific consent for providing a teletherapy? And I believe that in California, for example, there's a statute that specifically says you must provide, you must obtain consent, and the consent must be documented. It could be a oral consent, it can be written, but it must be documented. So that's always a key question. And right now in California, just last week, the governor actually suspended the statutory requirement to obtain consent for teletherapy just during the duration of this crisis. I know that Medicare has suspended the consent requirement. So we're seeing a lot of relaxation on some of these rules, but it's, and I can speak to this more a little later. I think getting consent, even if it's been suspended, I still think getting consent is a great idea. I think it's a best practice. It's going to be very important for making sure you get paid, particularly from commercial private payers. So I would highly recommend that you ensure that you get consent and document it. Other recommendations, or other laws that come up, of course, are the privacy laws, HIPAA, and the federal HIPAA law we all know about. And you want to make sure that you are having a platform that is HIPAA compliant. Right now, HIPAA has said they're not going to enforce a lot of those laws that say HIPAA. The HCR, it's known as the Office of Civil Rights, is not going to be enforcing a lot of the HIPAA standards for telehealth, just again during this crisis temporarily. So if you're using Zoom, the free Zoom platform, you're going to be okay. But normally, you wouldn't just be using Zoom. You might use the business Zoom, where it's a paid subscription. I think the prior panelists, they talk about some of the other platforms out there. So that's a great idea. Definitely do not use even right now any public-facing platforms such as Facebook or TikTok, things of that nature. You want to make sure it's a fairly private forum that you're using. So those are some of the key legal issues that will come up with teletherapy. You asked about ethics. This has been touched on, and Joe touched on it. The prior panel touched on it. You always need to make sure, even if legally you can provide the teletherapy, you need to ask yourself, is this the right thing for this particular patient? Is this patient going to be actually better off getting teletherapy versus not getting any therapy at all? It might be for some patients, you're better off just holding off on the therapy for the time being because it might be too risky to try to provide therapy over a telephonic or a video conference platform. So those are some ethical issues. I would say another ethical issue that I want to just touch on just very quickly. There's a lot of relaxation right now with the crisis. Federal and states are relaxing their requirements. And there's going to be a deluge of claims, and not just with therapy, all healthcare. Okay, there's a lot of relaxation. There's a lot of a quick transition to use of telehealth, and physicians are doing it for primary care. And so there's going to be a massive uptick on a surge, really, of claims for telehealth. And one of the things we want to make sure is that there's not an overutilization. Okay, so anytime there's standards are being relaxed, we need to be careful not to avoid the temptation to do things that we wouldn't otherwise do if we were providing it in-person care. So just using best practices and not letting the relaxation, the liberalization of standards create overutilization, and frankly, we don't want to see a surge of healthcare fraud as a result of these standards being relaxed.
Those are definitely great advices from both of you guys, coming from the ethical and the legal perspective. And I was wondering, many therapists are now being pushed to really use telehealth as something, a new platform, and learning on the fly, and basically are really struggling with a lot of the relaxation of the federal as well as the state laws. And I'm also wondering, and maybe Joe can answer this. Are there a lot of lawsuits that are common to telehealth as they are in vivo session? And what are some examples of potential lawsuits that are more focused on telehealth or violations of telehealth laws or ethics?
Well, actually, Jorge, they've been remarkably infrequent, at least as far as I'm aware, in terms of published cases. there have been a number of lawsuits brought, particularly back in the 90s, against internet pharmacies, where with the use of your credit card, you could get all the OxyContin your little old heart desired. There have also been quite a few cases brought by prisoners. A lot of telehealth is delivered to people in prisons for a whole lot of very good reasons. And the prisoners, after all, don't have a lot to do, and some of them are pretty eager litigants and file lawsuits on a regular basis. There's a federal, what amounts to a civil rights statute that they invoke, and most of the time they fail. Most of the time their cases are dismissed on what's called summary judgment, meaning that the judge thinks the case is so weak that there's no reason to have a trial. Occasionally, however, they do succeed. On the other hand, true, genuine med-mal cases, where there's a claim of a breach of duty by a practitioner of some sort that led to harm, have been remarkably few, and almost none has been published really in 20, 30 years. Now, I suspect that will change because we're seeing a much greater volume of cases now, and we're seeing telehealth employed in contexts where it has not been widely used up to this point. On the other hand, I've been making predictions that there will be more lawsuits for a long time now, and I've been a very poor prophet in predicting it. So the good news is that it's great for the provider. The bad news is that if you're a student of the subject, it's hard to get much in the way of instruction from courts that look at a set of facts, apply the law to it, and come up with a decision. We just don't have terribly many cases, at least that I'm not aware of. John may know more than I.
I agree.
Okay, so it sounds like it's a very new frontier for many of us. So we just have to wait and see who will be the poster child or case for not do or learn from. John, California is also very litigious, and I'm also wondering, and maybe this was not in some of the questions that we were thinking about, but many clinicians are using it as a one-on-one kind of therapy, and there have been questions that have been raised about group. Should I be using mental health for group therapy? And maybe Joe can also jump in if he knows something about that happening on the East Coast. But I've seen a lot of folks also who do group therapy considering using one of the platforms for group therapy. And I'm wondering whether you guys have any thoughts about that.
Yeah, I've definitely have some clients. I have plenty of clients actually who are using teletherapy right now, especially for a group therapy, and it's fine. I mean, you certainly, it's fine. I mean, always reimbursement is where you have to. I think group therapy via telehealth is fine. I mean, there's no reason why you can't hold, to my knowledge, where you can't hold a effective group session via telehealth. And I think that, whether it's really effective or not is probably a question best left for clinicians. But legally speaking, I think it's fine. I mean, you need to make sure the consents are there and all the same things you would normally want to have. I mean, if one of the members of the group is not located in the same state, then you've got that licensure issue that you're going to have to explore. But I think by and large, legally speaking, it's fine. Reimbursement wise, will payers pay for it? Check with the payer. I mean, make sure the payer is allowing for a group therapy to be reimbursed on a telehealth platform. My experience right now, what I'm seeing currently in this current crisis, where people are having to, we're here in California. I mean, we were one of the, pretty early on, we had stay-at-home orders. So it made perfect sense to have people participating in group sessions, not all in the same room, right? We were being told right away, can't have more than 10 people in a room. By now I think it's 6. So I have clients who are using telehealth for group therapy. And my understanding from what I've been checking is that the payers are okay with it right now during this crisis. And again, just like the states and the federal government have relaxed their standards, the insurance companies are having to relax their standards as well.
Okay. Joe, any follow-up to that? Any thoughts on that?
I would agree with John, Jorge. I think he's pretty much covered it. I do represent 1 or 2 psychiatrists who provide care in this fashion. They have told me, and I don't pretend to be a mental health professional myself, I'm not trained in the area, so take this with a grain of salt. But from what they tell me, one drawback is that in in-person group sessions, when the tendency arises, as occasionally it does, for 2 or 3 members of the group to break off and create their own separate mini conversation just among themselves.
Mm.
The therapist can interrupt that, first of all, can identify it quickly and can interrupt it fairly nicely, from what I'm told, by the simple expedient of walking over to where they are and standing close by. It tends to shut down that kind of activity and refocuses attention on the group. Whereas in an electronic setting, it's harder, A, to be aware that that's going on if it is, and B, to do anything about it in an effective way anyway, given the limitations of the technology. Apart from that, though, A, it's perfectly lawful as far as I'm aware, and B, from what I understand, in spite of problems of that nature, those who've tried it seem to think that it's effective and can be very useful. So I would give it, from at least from a lawyer's point of view, my blessing. From a clinician's point of view, I would defer to a clinician.
Yeah, and then from a reimbursement point of view, again, we have to go back to looking at what the payers are doing, the specific payers, and not every payer is doing the same thing. Unfortunately, I can tell you that in California right now, we've got the Department of Managed Healthcare and the Department of Insurance issuing all plan letters, which are basically guidance mandates really to all the payers and plans that are operating in California, telling them, hey, you've got to, if this service can be provided via telehealth, meaning that it's within the standard of care, and it's in the judgment of the practitioner that this should be provided via telehealth for XYZ reasons, then it's got to be covered. The service has to be covered, and it's got to be not only covered, it's got to be on parity. There's got to be a sort of a rate parity with the as if it occurred in person. So this is happening right now. As these things are very fluid, they're changing. Payers may not all be complying with these requirements. I imagine they're all aware of these requirements, but they may not be complying with them. They might be trying to figure out how to manage these things. And then there's a lot of questions about out of network. Are you still going to, even in these all payer letters, these all plan letters that they're issued by the state agencies, they're always carving out, saying, well, we're not forcing you to do anything with out of network. So there's always a big problem if you're out of network. Are you going to get the same treatment than you would if you had a contract with the payer? So there's a lot of big questions, and I think the best advice I can give anybody on these issues is you got to start with checking with the plan. And if it appears the plan's doing something completely unreasonable when it comes to reimbursement, then that's probably the time to start checking with lawyers or checking with the state regulators.
It's good to know that the government is also helping allow the insurance agencies or companies to really relax some of their regulations for payment, so that we can actually provide the services that is so muchly needed. Just a time check, we have a little bit less than 10 minutes to go. So I was wondering, are there, I know like the previous panel did address some of the clinical issues about clients or patients who are not as appropriate for telehealth, but are there particular legal issues that we should be concerned about having someone in through telehealth? And if I can contextualize a bit about the question, I've also heard from some folks that can we not provide the options for the patients to be able to come in person as compared to just telehealth? And I'm wondering whether from the legal side, you guys think that there are some cautions that we should be aware of as clinicians, because we always want to see them in person, but telehealth is an option. And are there words of caution that we should be thinking about?
Who's up the bat?
Start, Joe.
All right. Okay, Joe. Well, as far as I know, and again, I'll defer to the clinicians. As far as I know, though, there are no clinical contraindications to telemental health services. I indicated early on that it's important to recognize the limitations inherent in the technology and the fact that you can't, for example, look at the person's full body. You're likely to be able to see the face only, probably, or not much more than that. And to the extent that seeing other things is important clinically, that's a factor to consider. I also mentioned, I think that, at least in my mind, a particular concern in mental health, obviously, is suicide. And if you're caring for someone who experiences or is experiencing suicidal ideation, I question whether telehealth is the ideal way to do that, to take care of that. But now you may have no choice, in which case you do the best you can, I suppose, just as you would if you were, say, on the phone with a crisis intervention or suicide hotline type of situation. But there again, knowing what the emergency services are in the community would be helpful. With respect, though, to the option to offer in-person service, I'm fully supportive of that. In this era, this peculiar circumstance we find ourselves in, that's more challenging than it is under normal circumstances. But even so, there are just times when that's the better way to go. Something that may be worth considering, in fact, is that recently, not so recently as the COVID epidemic, but back, I think, in 2019, the rules regarding Medicare Advantage programs changed so that telehealth services could be primary services that those programs offer. But with the understanding that if MA funds are going to be used for telehealth, it's obligatory, it's required that the patient be provided the opportunity, the option to select in-person care if that's what he or she prefers, in lieu of distance care. So not only is it a good idea, in certain circumstances may actually be legally required.
Okay. Anything else to add there, John? Or that's
I think Joe covered it pretty much. I guess the one thing I would add is that, even in the midst of this crisis, and I can't speak for all of the states, but here in California, we had these stay-at-home orders, but healthcare is exempt from that. Healthcare workers are exempt from that, and therapy is not. It's not cosmetic surgery, right? It's not something that necessarily is going to get pushed out, to the extent that we're being told, well, all elective procedures need to be postponed. Therapy isn't necessarily the equivalent of an elective procedure. This is essential healthcare, and while it's preferable to go to a teletherapy format right now because of the social distancing requirement, or I say requirements, but really the desirability of that. There really isn't anything that I'm aware of that says you can't provide in-person care. If in-person care is the appropriate thing to do in the judgment of the professional, then I don't think that anybody's going to get pulled over when they're driving to the facility or their office to provide that in-person session. I don't think they're going to get pulled over by the police saying, "Oh, you're not complying with the stay-at-home order." Okay, healthcare really is exempt from that, and I think this falls squarely within that exemption. So I think that's one thing I'd want to point out.
Okay. Well, thank you. Also, Joe mentioned earlier that Medicare had relaxed some of the laws to allow for kind of just call-in or audio-only sessions. Could you maybe expand more if there's any more updates in regards to the Medicare allowance for that?
Well, the truth is, Jorge, that I'm struggling to keep up with the changes that are occurring. It's almost a full-time job just to find out what happened yesterday, somewhere in either Washington or one of the state capitals, or more likely multiple state capitals. But Medicare has undergone a sea change with respect to its approach to reimbursement during this crisis. I frankly never expected to see the changes in my professional lifetime that I've seen in this last month. There have been many rules that have been waived. Perhaps the most notable of them is that it used to be the case that to be eligible for reimbursement, the patient had to be in a rural area effectively and had to be in some sort of healthcare facility, a clinic or a hospital or a doctor's office or something. Whereas now it doesn't matter where the patient is. It could be the middle of Manhattan or it could be in the middle of South Dakota. And it doesn't matter what building the patient happens to be occupying at the time. It's all good from Medicare's point of view. That's a distinct change. There's also been a liberalization of the kinds of providers who can bill. There was originally about 8 types of practitioners, mostly doctors and advanced practice nurses, psychologists. I mean, logical choices, but by no means people, for example, like OT and PT, et cetera. Now those folks can bill. There's been an addition of something like 80 new codes that are eligible for reimbursement under Medicare under telehealth. Up until a few weeks ago, out of the entire 10,000 or so codes out there, Medicare reimbursed for only about 100. Now, in the space of a month or less, that number is almost doubled. And by no means is this a complete list. In fact, I maintain a cheat sheet that I refer to fairly regularly because of the number of changes that have occurred and the rate at which they are occurring. I've never seen anything quite like it. It's in fact, the government has waived a great many requirements under the Medicaid program, for example. It has invoked the power that it has under a certain section called 1135 of the Act that is invoked only in emergencies. And there's a whole plethora of waivers that have occurred, and an invitation to individual or institutional practitioners or providers to request more. If on this list of multiple changes you don't find one that suits your needs, then contact us and we'll consider it. It's an open-mindedness that is remarkable and refreshing. And I'm sure that's not remotely a complete list. That's just from memory. John can probably add several more.
I agree, Joe, and it is. I also I check every day. I have to check every day to see what the latest is, because it's changing minute by minute, it seems. I think what's really fascinating is to see all these changes happening so quickly. Are we going to see a big rollback if we get to the point where this crisis is abating? And I say if we get to that point, I mean, I certainly hope we get to that point. But is there going to be a very quick, swift rollback? I don't think so. I think a lot of the things that we're seeing, some of it's going to get pulled back. I think OCR is going to go back to enforcing HIPAA, for example. But I think a lot of the codes that are being allowed for teletherapy, I think we're going to see a lot of those going to be entrenched when this is all over. Medicaid, or at least Medi-Cal in California, they've been allowing audio sessions for quite some time, with the recognition that not everybody, the population who's using who's on Medicaid, and often with Medicare, it's a population that doesn't necessarily have access to the technology that you and I take for granted, and then it's allowing us to do this particular form we are doing right now. So telephonic sessions are pretty widely accepted with those government programs. Now you get to the private payers, it gets to be a little more tricky. Some of the guidance I've been seeing when it comes to telephonic sessions is they say, well, we'll allow it if you can document a need for it. So the patient needs, there's got to be a patient need for the audio only session, and it should be documented, which kind of goes back to the issue of consent and why you want to have a patient consent, specific consent for teletherapy, even if the state or the federal government's not currently requiring it. You still want to have it there to show this is why we're doing this telephonic session. The patient's consented to this. The patient has expressed this need to do this audio only, and I'm documenting it, I'm putting it in the record, and so that when you submit the claim to the insurance company, you're at a much better chance of getting paid for that service.
Well, gentlemen,
that actually,
go ahead.
I wonder if I can make two quick points that John's mentioning of the audio only triggered.
Can you be quick, as we're basically out of time? I just want to thank you before we actually go off, and I'll let you close up with his point, if that's okay with John too.
Absolutely.
Go ahead.
Well, okay. Well, the first was simply that, to my astonishment, it's now possible to use phone only to prescribe controlled substances in appropriate circumstances. And second, the fact that you can use phone only now does not change the rules of malpractice. And you should be cautious about professional liability in electing to use that form of care, especially for a brand new patient you've never seen or heard from before.
Well, thank you again for taking the time and sharing your words of wisdom and knowledge in this very rapid changing COVID environment. And again, for the viewers, thank you again for joining us. There are resources in the TogetherWell, I believe it's the expo session, so please go there. Otherwise, we will leave and bid you guys a good night, and please continue with the next panel. So for those on the East Coast, Joe, it's basically bedtime for you probably. And for John in LA, stay safe, everybody.
Thank you.
Have a good night.
Bye.
Good night.